All right. Hello, everyone. Thanks for joining us for the Mandated Reporting and Best Practices for Supporting Families session. I'll introduce our speakers soon, but first, a couple of reminders. This session is recorded and will be available on the conference platform 1 hour after the session ends. We do want to hear from you in the chat, so feel free to ask questions or comment in the chat box on the conference platform. We recommend using the conference platform chat feature because that chat will be recorded with the session. Please do keep yourself muted unless the presenter asks otherwise. And so at this point, I'm excited to turn it over to Kelsee Fout and Erica Hunter. So ladies, take it away.
Thank you so much, Chrissy. My name is Erica Hunter, and you are at the Perinatal Substance Use Mandated Reporter and Best Practices for Supporting Families training today. We're really excited to be able to talk to you guys for the next hour and 15 minutes about this topic. And so for today, things that you are going to learn about are kind of understanding your role as a mandated reporter and the process for making reports, to understand the use of the perinatal provider workflow during work with pregnant and postpartum individuals, to kind of walk with us as we reimagine a system and society focused on prevention strategies to reduce child abuse and neglect, and to learn about some of the Kansas practice model. So I'm going to hand it over now to Kelsee, who will introduce herself and get us started.
Erica. Hi, everyone. I'm Kelsee Fout. I serve as a maternal and child behavioral health director at the Kansas Department of Health and Environment, or KDHE for short, and I'm in our Bureau of Family Health. To get us kind of started today, I am just going to do a little foundation setting here with terminology and language that will be used throughout the session, specifically around perinatal periods. So perinatal really means the period around pregnancy. So that time period in which someone has become pregnant through 12 months postpartum. So the important things to remember about this is it's not just postpartum and it's not just moms. We're talking about all birthing people and their support partners when I refer to perinatal. Also, mental health. I use this as kind of a general umbrella term for just kind of that foundations of emotion, thinking, and communication. Everyone has mental health, and what kind of differentiates what we're talking about today is a mental health condition versus the status of like your mental health or well-being. And then behavioral health, similarly, I'm using that as kind of this umbrella term that includes both mental health conditions and substance use disorder. Again, just a little bit of a level setting here. So what we know is about 1 in 5 women and 1 in 10 men experience a perinatal mental health condition. Women of color are 2 times as likely to experience postpartum depression and are less likely to receive treatment. Women experiencing a perinatal mood anxiety disorder are almost 20% more likely to also co-experience a substance use disorder. And we also know nationwide, but also true in Kansas, that drug overdose is one of the leading causes of pregnancy-associated deaths. So again, this is not just postpartum. These disorders occur just as frequently, if not more frequently, during pregnancy as what they do during the postpartum period. Some risk factors for experiencing a perinatal behavioral health disorder are included on the slide here. I'm not going to read them all off to you, but I think all of these should probably look pretty familiar. Some other risk factors for experiencing a mental health or substance use condition during the perinatal period could also be experience of trauma, any kind of stressors around the birth of the child, if there's any health conditions that happen with the child, any prolonged NICU stay, any history of experiencing a mental health or substance use disorder, also things like food insecurity, housing insecurities, those kind of factors all play into experiencing this condition during that pregnancy and postpartum period. Some risk factors for experiencing a mental health or substance use condition during the perinatal period could also be experiencing of trauma, any kind of stressors around the birth of the child, any prolonged NICU stay, any history of experiencing a mental health or substance use disorder, also things like food insecurity, housing insecurities, those kind of factors all play into experiencing this condition during that pregnancy and postpartum period. And experiencing behavioral health conditions have impact on health and well-being of mom, but also on the entire family unit and including the development of the child. So it's super important to catch conditions or identify conditions as early on as possible, and start making plans with that mom for what additional support could look like, whether that's kind of a peer nature through other like parent support, or something more formalized like actual um sorry, I lost for words there for a second, like counseling or therapeutic pharmacological intervention. And what we see in Kansas through our Kansas Maternal Mortality Review Committee is from the time that this committee was established and started reviewing maternal deaths in Kansas, there have been 153 pregnancy associated deaths. Almost a third of these deaths were caused by homicide, suicide, or poisoning or unintentional overdose. Mental health conditions contributed to about a quarter of those, and substance use disorder contributed to about 31% of these deaths. Also, what we know through Kansas data, specifically our PRAMS data, so this is moms in Kansas who delivered in 2021, is that about 30% of moms experience anxiety during pregnancy, about 20% experience depression, and about 6% experience substance use disorder during their pregnancy. And then specific to the postpartum period, we collect postpartum depression data, and almost 14% or so experience postpartum depression. And what is kind of surprising to me is of those that experience postpartum depression, about 15% did not get treatment for those symptoms despite a perceived need for that. And the reasons why they quote not getting treatment for their postpartum depression is the process seemed too difficult or overwhelming. So I think that's really plays into the role of a home visitor and some support that you all can provide. So I'm hoping that you find this information really valuable and can help with some of your postpartum home visits. So what happened with our maternal mortality review committee based off of the data they were reviewing is they made some formal recommendations. And the big one that I want to take away here is that screening, brief intervention, and referral to treatment, or that SBIRT process. And so they're recommending that universal screening occur for mental health conditions and also substance use disorder. They also have in there that recommendation around social determinants of health because of those risk factors at play during the perinatal period. But for the purposes of this presentation, we're focusing on those mental health and mostly substance use disorder screenings and referrals to treatment. So when we started rolling out this based off of the recommendations, we started providing provider training on the SBIRT model or the SBIRT process. The evidence base for SBIRT is really rooted in substance use. But we kind of use the rationale that this process could be applied to any health risk behavior. So really, you should be universally screening for a health condition and making sure that a conversation occurs regardless of the screening results. So that way that individual knows the outcome of their screen. This also eliminates any kind of bias that happens through a screening process. We're not selecting one person because of their race, ethnicity. We're not selecting them based off of their insurance type or lack thereof, or their education. Everyone is getting screened. That ensures an equitable process. It also ensures that if someone might be not presenting with symptoms, but definitely experiencing them, you're able to have that conversation. So we recommend universal screening practices using a validated screening tool. That's also really important. So again, when we rolled out this training, we were immediately hit with some provider concerns. that this, especially related to substance use, opens up a can of worms. That there's, especially around mandated reporting, and not really sure what happens with the mandated reporting process if a pregnant woman does report that they are using substances. From a healthcare provider perspective, they wanted to make sure that if they were to make a report, that they weren't going to have this broken trust or rapport with their patient. They wanted to make sure that the patient engaged in prenatal services, because that is like what is best for mom and baby. And they really just like wanted more clarification on this. And so we reached out to our partners at DCF and created this workflow. And I can put a link to this in the chat. I know it's kind of difficult to see on the screen. But we worked really closely with DCF to create this workflow to really increase transparency around the process. And then through that, we're like, some additional training might be helpful. And that's where Erica and I kind of created this training and have been facilitating this in several different spaces, hoping to increase awareness of the process and how to best support families. So with that, I'll turn it back over to Erica.
Thank you. All right, so I'm going to just really briefly, we always like to just acknowledge that probably the majority of you guys are what we consider mandated reporters according to statute. And for mandated reporting, that is when a person has reason to suspect that a child has been harmed as a result of physical, mental, or emotional abuse, neglect, or sexual abuse, and the person shall report the matter promptly to DCF and or law enforcement. So as I'm talking, we're really going to be focusing on that perinatal period. So we're not going to really dive into all the other things that might be happening. We, again, are kind of really focusing on this perinatal period that is as it relates to substance use. So as you guys might be working through those cases. Oh, I lost my, where'd you guys go? Okay, there you are. All right. So the next thing is just kind of like getting everybody acclimated with thinking of when to make a report. So again, you guys are probably in a unique situation because you might be interacting with people that are pregnant using substances who maybe just given birth. They might be just a parent who's currently using substances. They have older kids, or it may just be related to abuse or neglect that has nothing to do with substance use. So again, you guys kind of are in a unique position compared to some other mandated reporters. So as we think about kind of what it means with mandated reporting, we're going to start first kind of with the pregnant women using substances. So this is one that DCF has had for a while. We can assist if we need to with these type of cases. What I would say is it's not required per statute that you have to report them. We always would encourage how can you support that pregnant woman first before needing to contact DCF. DCF does have some services we can offer, but we do know that communities oftentimes have some really great supports. And also sometimes that can be one of the reasons that people aren't honest, or they're not telling you that something might be happening that they're using, or they don't seek out prenatal care, is because of this fear that DCF is going to be called. And then the fear for kind of like what those ramifications might be if DCF does get involved. So again, this is something that we can assist with. And a lot of times the pregnant women using substance cases that we end up getting involved with have a lot higher risk factors happening. So we see it's usually pregnant women who have had no prenatal care. They're ending up in the emergency rooms. They're homeless. They have mental health issues. They're domestic violence. So it's usually ones that really don't have much of a support. They don't have many protective factors. And so I think those are the cases we end up oftentimes getting involved with. But there are things, DCF is a resource if for some reason you're feeling that we need to be involved, but it's not anything that is you're mandated to report if it's a pregnant woman using substances. I'm going to go more into the infants born positive here in a second. So I'm just kind of like gonna move past that one really quick because we'll dive more into it. So again, some of the other type of situations you might get more involved with are things that have to do with just abuse or neglect of that newborn as they age, or of maybe a sibling that's in the home, because you might be working with them. And so that goes back to just what the statute says as far as mandated reporting. When you think of those cases and whether or not you're suspecting that there is some sort of harm due to abuse or neglect. Next slide, please. All right, so here's where I'm going to go more into about infant positive for substances and substance affected infants. So currently, there is no statute or regulation that really says for an infant positive for substances needs to be reported. So if you have infant that's born positive and they're in the hospital, and it was maybe marijuana that the substance use was, that doesn't necessarily mean that you have to report it. So some of the things that we like to kind of talk about a little bit more are, how do we really think about the risk and safety and danger of this infant as we think about them going home? And so there's a safety scaling question that you can kind of change it to what might fit, but this is a question that we sometimes will ask. And as a reporter, you may have been asked this question at different times. So consider safety scaling on the infant. And this could be even if you are working with a parent, they're in the home. So you guys are at home, you know that there was substance abuse concerns, maybe the infant was born positive at the hospital. And so you're aware of that. And so this is something that you can kind of ask yourself as you're interacting. On a scale of 0 to 10, where 10 means the child is completely safe right now, and 0 means that if there's no action taken, the child could be seriously hurt or injured in the next day or two, where would you rate the situation? And so again, that can kind of help you as you are working with something. If you know the parent that you're visiting is using marijuana on a regular basis, or if you know that maybe they had pain pills and they seem to not really be getting off of those, starting to think about what that might mean. And so as you think about safety and risk factors, there's a lot of different things that can come to mind, especially with substance use. And when you have an infant who really can't, like they don't have much ability to protect themselves at all, it really is on that parent. So there's going to be the risk factors or safety factors that you see. Do we have a parent who, because of their substance use, is, they don't have housing, so we see them either homeless, living in a motel, bouncing around all over the place? Are there mental health issues? Is there domestic violence from their partner? Do we see that because of substance use, they are sleeping a lot? We're worried that they're not feeding the infant as regularly as they should. So I think there's a lot of different things that we can consider. And then we think of our protective factors that we have. Do we have a caregiver in the home who isn't using substances and who really is kind of taking over that care while this parent maybe is getting some help? Do we have a network of people with that family? Do we have service providers or professionals that are in that home working with the parent on different things that might be happening? What community supports or referrals are you able to help make if we see a need that family has? And so that kind of is the same for substance affected infants. Substance affected infant, though, right now is considered neglect. And that actually is going to be changing in January. So for federal reporting, we still will report out if we have a substance that's affected. And that's due to some of our federal regulations and everything that we have, is we still need to be reporting out how many infants do we have affected by substances that are born in Kansas. But we're going to be shifting that, and it's probably going to be in July. We're working to see if there's a few other things we can do. And Kelsee's actually on some of those groups with us, helping us work through all of this. And so as we look at that, we are going to not be having it be a neglect allegation any longer, but it will be a family in need of assessment. So it'll be a similar type of case as our infant's positive, except for it's really focused on those that were actually affected by it. And when an infant is affected by the substance, we have to do what is called a plan of safe care. So really that is making sure that Is that infant going to get all that follow-up medical care that they need? Is that parent getting the support that they need? What medical resources do we have, or do we need to make referrals in order for that parent and that infant to get what it is that they're going to need for the kind of that long-term care? And so that's really the difference. Is our infants positive for substances, there's no effect. And so we don't necessarily have to do what we call a plan of safe care. That's that ongoing seeing what we might need to do. And so it's confusing. And so a lot of times, we completely understand that. So we're really trying to figure out how can we help work with the communities on both of these types of cases. And is there a way that even our substance affected infants don't have to be necessarily reported to DCF, because our communities can help us find out what that long-term care really would look like for the families. But the main thing is for infants positive, we just like to kind of make sure that we're communicating, the infants positive is really about do you have a safety concern? Is there a risk that is a high risk for that infant? And if there's not, you don't necessarily have to report. It really is about what is the harm or suspected abuse or neglect you might be worried about. So next slide, please. And so this is a little bit more, so some of that federal legislation I was talking about, it's under what we call CAPTA, which is the Child Abuse Prevention and Treatment Act. And there within that is the Comprehensive and Addiction Recovery Act, and we call it CARA. And so with CARA, as a state, we have been looking at how we've implemented CARA. It came about in about 2016. And we want to see if there are different ways that we can do the work with that population. And so that is where the substance affected infant, we would not be considering it neglect. And so we're kind of looking at how is it we can collaborate more between DCF and medical? How can we look at those plans of safe care being done by medical providers, or maybe in-home service providers, somebody who's really working with that family, versus it being kind of DCF, which again, from working with Kelsee and all the research that they did with their group, is one of the biggest reasons people don't seek out treatment, don't talk to their providers to get help, is that fear of what DCF is going to bring into their life. And so really focusing on that prevention and support, and how can DCF really become more involved in the cases where it's high risk or there's actual danger that might be happening. So. And so I'm not going to touch on this a lot, but I just like to bring this in to the conversation, is the really thinking of that impact of poverty and bias that oftentimes happens with reporting. And so with bias, we don't even realize that we're bringing it in. So we come in with this predisposed judgment about families sometimes. And again, we're not doing it intentionally. And a lot of times people, they don't realize that it's even happening. And we've had so many conversations and I start to reflect sometimes on my past work that I had, or different things that I'm bringing into a conversation. And I realize that I sometimes have this implicit bias. It's a good way to be able to have conversation, to open up, where is that coming from? Why am I having this thought right now? Let me talk this out. We also know that poverty, again, when there's poverty that is involved, there's oftentimes many other barriers and challenges for parents, but that does not mean that they don't want their child to be safe, that their child is unloved, or that they don't have the capacity to be able to care for their children. And so really working in that context. And in Kansas, actually lack of financial means for specifically like neglect cases is not a reason for DCF to become involved. And that is a movement even across the United States they're trying to get to, but Kansas kind of is already ahead of it, is we already have some of that in our statutes. And so knowing that if a parent does just really lack the financial needs to be able to provide certain things, that really isn't considered neglect. And so how is it that our providers, our communities can help with that? So if you're looking for more in this shift of kind of perspective, Kansas Children's Service League, or KCSL, has some really great trainings that can dive more into this topic about the shift in perspective as it relates to implicit bias and poverty and neglect. So I will put that in chat here once Kelsee takes over here in a minute on talking again. And so one of the questions I like to ask, and so if you're willing to put this in chat, is I really like to ask you guys, what ways have you seen poverty impact perinatal caregivers that you have worked with? So what are some of those things that you see poverty really impacting as you think about some of the families that you're working with? There's no wrong answers. Just put what you think. Oh, my battery's running low. I better plug my thing in. Sorry.
Looks like you have lots of responses rolling in, things like transportation, nutrition, getting prenatal care together, having insurance and being able to get to appointments, access to medical care, discrimination in healthcare, lack of food, couch surfing, food supply for pregnant moms and adequate living conditions, more transportation, housing, no prenatal care, no car seat, things like that. Yeah, a lot of great lists rolling through there.
Wow, and it's coming in fast. And one of the, I keep seeing like unsafe sleep type things, unsafe or beds and sleep in it. And that's one of them that I actually hadn't thought of was, you know, sometimes the ability to be able to get more of that safe sleep set up for newborns. So yeah, there's a lot, right? There's a lot that really is impacting our families as we think of how poverty might be impacting them. All right, Kelsee. All right, so these are just some super quick tips for making a report. So always include your email address. If you're a mandated reporter, you should not be ever reporting anonymously. You cannot receive an event ID, which means that we can't really say yes or no, you did report. Plus, we might want to ask you some more questions. We always encourage you to have your the person you're working with sign a release of information. This helps collaboration and streamline of services work out really well. And a lot of times people are like, well, I'm not telling them I'm making a report. And so that's one of the other things is if you feel like it's something where you're safe, the child is going to be safe, and the person you're working with is going to be safe, by telling them that you're making a report, that is okay to do. And that actually can help maintain a relationship. And it can also assist with, again, that streamlining services with DCF and kind of helping coordinate. You could even make a report together with that parent. So if it's something that you're like, I need to report, and is it something that you feel like you could have that parent sit with you while you are making that report? And also, really thinking of using that provider consult line for the perinatal behavioral health resource. So again, what can we do to get everybody kind of on the same page and really thinking of that prevention work at all possible as we're working through this? All right, so I'm going to run through some really quick stuff. And so some of this is going to bring in some of this practice model, the Kansas practice model perspective. That's kind of the shift. And so when making a report, we just need a lot of information from you, but some of the stuff is really about the impact. So we like to know, what is the impact that child from what it is that you know has happened, or what is your concern the impact might be if things were to continue the way that they are. We also need to know who's involved, what's happened, when did it happen, where did it happen. And this just goes back to a large number of the reports that we've received through our online web reporting. We don't get sufficient information, so we can't actually make a decision, which causes us to delay our decision making, which could impact that child's safety if they're really in an unsafe situation. Next slide. So if you have made an online report recently or called DCF, what you might see is that you are getting asked different information. And what we're doing is we are trying to ask more balanced information. So in child welfare for years, what we've seen is that people really focus only on the worries and what is not going well for a family. And so we want to kind of shift, and we don't want to only be focusing on what isn't going well. We want to also know what has worked well in the past. What services do they currently have? Has there been a time that that family has been successful, that they've been thriving? What was different? So we're going to ask you scaling questions. So like that safety question I asked earlier, we're going to ask about your worries, but then again, we're also going to be asking a lot about the supports, outside supports, what you've done for the family, that past thing, anything that in the past has gone well, what did it look like? And then another question that's kind of unusual is your best hopes. So we want to know from you, like, what really do you hope to see happen for this family? And we want to know what you think the next step should be. What do you think should happen? And also kind of getting an understanding of what your worst fear is if there's no DCF intervention. And again, what this information does is it helps us get a better idea of what breaking down more of what your worries are, and sometimes getting into some of those biases that we don't even know that we have. So we unintentionally bring in things as we're making reports, and this kind of helps break down some of where we might see some of that. So how that decision's made. So after you've called in the report, we go through and we look at, first, does it meet our abuse or neglect criteria for investigation? Then we look to see whether or not it meets. If it doesn't meet that, then we move into our family need of assessment criteria. And basically what we have at the end is our initial assessment decision. So we are either assigning for further assessment of abuse or neglect or a family in need of assessment, or we are not assigning for further assessment. And we are at about, right around 50% of the reports that get called in are assigned for further assessment. We do know that there's about 30% of the reports that we receive through DCF end up being family in need of assessment cases. So cases where it's actually just looking for support or services for a family, but there's not abuse or neglect. And so I think that's where we really want to continue to have these conversations with communities and people like you who are in the homes doing the work about what is it we can do to keep supporting those families and finding those services, making those referrals when we can for that prevention work, so that DCF isn't the one needing to interact with those families where there was not abuse or neglect. It really just was that family needed some additional supports and services. And we will acknowledge that for years at DCF, we were out there promoting, don't ask any more questions, just call and report as soon as you have a concern. But we realized that that was not helpful for families, that it overwhelmed the child welfare system. And so it is okay to ask a few more questions. And sometimes by asking a couple more questions, you can get a more clear picture. Is it poverty that's really impacting it? What barrier do we have? And so again, that goes back to, if you're more interested in hearing more about that shift in perspective, the Kansas Children's Service League really has a good training on what that looks like and different ways that we can support families. So I would encourage you to go to that training. Next.
Now we do have a question in the chat.
Yeah.
The comment is that people are really scared about DCF taking their children. And so she's wondering about the types of organizations that can really kind of help moms kind of get a clean slate, helping with organization, time management, things like that. Do you have any resources that you'd be able to recommend or direction you could go for that?
So, I mean, each community is going to be different on what there is that can help. And so, I know that again, the Kansas Children's Service League has the 1-800-CHILDREN, and it's a website as well. So I'll put that in there too. And it has a variety of different resources. And so I think that, sometimes this may even just come down to, is there an organization that has money to be able to pay for mom to have somebody come in and really help her organize her house, to be able to get things cleaned up? And so, or is it based on, are there mental health issues that maybe mom has some underlying mental health concerns? And if she had those, somebody working with her on those, would that help? And so sometimes it's just kind of digging in a little bit more to get to what is the underlying reason for some of that unorganization, and who out there can really support. And so again, is DCF really the best support if it's not really about concerns that somebody is neglecting, but it's more concerns about an overwhelmed parent, a parent who doesn't have financial resources to do something, or a parent who might be lacking some of those supports or services. And Kelsey did put in the chat that 1-800-CHILDREN, so I appreciate that. Thank you.
Yeah, an often overlooked resource can often be the managed care organization or MCO. They have some different value added benefits for Medicaid beneficiaries. So depending on the status of the house, I know a service, as an example, would be like bed bug issues. I don't know if that's spraying or what exactly that is. Are also like cockroaches, like they can help with all of those kind of like actual treatments for a housing unit. But there might be other value added benefits available through the MCO that could help her depending on like what exactly the issue is within the house. So that's something you could also explore.
Especially if it is impacting somebody medically and they have a medical card, they are a huge resource to be able to reach out and see what assistance they can give. Yeah. So DCF, kind of the role that work would be going out and doing the assessment in investigation with that family is they're doing a lot of assessments. So they're doing risk and safety assessments, kind of not needs assessments necessarily, but through those assessments, they're understanding what needs the family might have. They're making service referrals. So a large number of the service referrals that DCF makes are actually just to community referrals. And so I think that's where just really trying to empower the communities to start learning about all the different resources that they have in their communities so that they can make those referrals directly. Kind of thinking of there's no wrong door for somebody to come and ask for help, and then somebody can help figure out where that resource or what resource might be able to help them. And it doesn't have to be the child protection agency that is manned with like really just doing those service referrals. We also make a finding decision if it is abuse or neglect case. Our family need of assessment cases do not have finding decisions on them. We're helping really build safety with families. So it goes back to that walking alongside families, nothing about you without you, and really just providing that support in the, with our goal being that we don't have to continue to interact with them, that they're able to find their network. And if there's services that might be needed, how do we make sure we connect them with those as well? So just something else we like to bring forward as we're talking to people is thinking of, a lot of people always think of DCF as really the child protection agency in foster care, but there's a lot of times that foster care is not really the end result that we see. And one of the things that we really try to do is how do we keep kids in the safest environment that they can with people that they know. So prior to a child being removed from the home, one of the things that our staff will be doing is kind of asking these 4 questions. And these 4 questions came out of a pilot in Iowa, and it was judges who actually created these. And so the questions are: first, what can we do to remove the danger instead of the child? Can someone the child knows move into the home to remove the danger? Can the child and the caregiver go live with a relative or a friend, or could the child temporarily move with a relative or a friend? So again, it's really thinking of what can we do so that we don't completely disrupt this child's life, because we know that that is a huge traumatic event for any child. And so that's really looking at what can we do to remove the danger from the situation that child might be in, and using foster care really is kind of that when there is no other protection available for that child. And so again, this goes back to the nothing about you without you. There's all the things you see right there are really just parts of our practice model. And I just want to highlight them. I'm not going to go over all of them with you, but family voice and team decision-making are huge. The family should be involved in every decision that we are making. They should be aware of what's going to be happening so that we're no longer kind of this surveillance, just watching over, waiting for somebody to fail, that we're having conversation, that everybody's on the same page, that people understand what the expectations are. And it should feel like a different type of relationship than what people maybe had with DCF 10 years ago if they had been involved. So again, not going through all of this. If you're more interested in some of that stuff, I can for sure connect with you afterwards and we can go over in more detail what some of those might be. The one I did want to highlight is about our immediate safety, though, because this is probably one of the biggest ones that a lot of people really want to know more about. And so immediate safety is we're really looking at what factors are increasing the danger, so making it unsafe for that child or infant, and then what factors are increasing safety, and so making it where it is safe. And so there's going to be all kinds of different things, but these are just types of things that we can think about as it relates to child vulnerability, child's capacity to protect themselves. What is really that threat to immediate safety, and safety and risk are two things that we've really been working with and trying to continue to connect with our community partners more on, about everybody kind of having that same definition of what is risk, safety, and danger. Because a lot of times I think we're intertwining those, and we see that things that are risk factors, oftentimes people think of it as danger. And so how do we really help everybody kind of understand what it is that might actually be a danger versus what is a risk factor, and where that decision making comes in. And so our immediate safety is just something that our staff should be, every time they're having contact with that child, they're kind of doing an immediate safety assessment to think of, if I leave this house today or in the next 24 hours, how safe is that infant going to be? So really that's our immediate safety. And so our risk is really looking at, in the next month to years, how safe is that child going to be, based on what we know today, if nothing changes. So those are kind of just to help you guys get a better understanding, just as we talk about risk and safety and danger, what it is that we might mean. Service decision. So again, our community referrals are the highest that we make. We make a lot of community service referrals. We also have family first prevention services. They are different in every county. And so if you're interested in which ones are in your county specifically, you can look at DCF's public website, and it will have information on there about our family first providers by county. And so you could go in and read what services DCF has available. Then we also have family preservation services. It's been around for a long time. And then we have our foster care. So all of those DCF services are for children that are at risk of coming out of the home. So, that is where we say our community services and the support that is provided there are our first stop at trying to see what we can do to provide that support to families. Because if DCF is making a referral for any of those services we are able to give access to that family to, it's because that child is at risk for coming out of the home at that point. They've been assessed at a very high risk for coming out of home.
I'm going to share a few resources that are available before we get into some case studies. So the Kansas Connecting Communities program is something that is housed here within KDHE. It is the state's perinatal psychiatric access program, and we help provide support to the entire perinatal workforce. So we are a workforce program, not necessarily a direct service program or a support for perinatal individuals, but more so for the providers like you all. So through our program, we established a psychiatric consultation provider consultation line. So through that, it's staffed by a social worker with perinatal mental health training. This is toll-free to any Kansas provider working with a pregnant or postpartum person. If maybe you have done one of those screens and have some questions about what to do next, what are my next steps, you can call and talk to our social worker, and she'll help provide some resources or help support a referral to a community treatment provider. We also have on contract a reproductive psychiatrist through this consultation line. So if you are a prescriber working with a prescriber and you're trying to figure out what medication is safe to start during pregnancy or what is safe during the lactation kind of period, call and talk to our psychiatrist, and she can help provide some best practice information around prescribing. Also available is free training and technical assistance. So if you want more trainings like this or more information about perinatal mental health or perinatal substance use, our team can provide in-person or virtual trainings for you or your staff or your community. And then the technical assistance is really specific to screening implementation. So if you want to start screening, or maybe you want to perfect your screening processes, that's something that our technical assistance team can help you with. PDHE also has created this like centralized resource repository that includes like our mental health and substance use toolkits. On this is some information. It's a great place for like where to go if you're wanting to get started with screening implementation. So there's screening tools there. There are educational handouts that you could give to your clients. There are sample workflows, sample policies, all of that. This is great, again, resource center for you all. In Kansas, we also have designated women's substance use treatment programs. So there's, as of last month, there are 9 across the state. 6 of those allow for dependent children of women to also reside on site while the mom is participating in treatment services. So this is residential substance use treatment. In Kansas, to qualify for substance use treatment, an assessment has to be completed by a licensed addictions counselor. So someone who's doing a screening cannot make a determination by Kansas regulation of whether or not that person needs substance use treatment or not. If you are doing screening and identifying that substance use is there and it appears to be impacting their functionality, or maybe we're kind of creating some additional risks because there's children now involved or she's currently pregnant, you're making a referral to a licensed addictions counselor for a further assessment to be completed. So if you are aware of any of the substance use treatment centers across the state, you can definitely work with any of them that are local, whether they're a designated women's treatment program or not. Anyone can complete that assessment, and then they'll help provide that care coordination to the correct level of treatment based off of that assessment. If you're not sure who might be in your community or might be available to do that assessment by telehealth, you can call Carillon Behavioral Health of Kansas, and that number is listed on the slide there. And then some general support resources. The National Maternal Mental Health Hotline launched Mother's Day of 2023. So it's a couple of years old, or a year and a half old now. This is a support resource for any perinatal individual. So whether it's mom, care, other support person, the father, anyone who might be kind of struggling is welcome to reach out to this toll-free service. Postpartum Support International also has a Kansas chapter, and they have support coordinators that can help individuals get connected to additional supports across Kansas as well. And then, of course, 988 is your go-to resource for any kind of mental health or substance use crisis situation. You could also like direct your client to go to the local emergency department if that's an available option for you all. All right, with that, I think we can get into some case studies.
Thank you. Okay, so one of the things that we kind of like to do is bring forward some cases that have been called into DCF and kind of like talk through those with you guys. And so we will ask you some specific questions to kind of guide us through conversation with this. So the first one is, we call them the Harris family. So this family, we had mom and dad reside together. Mom has extensive history of drug use and admitted to using methamphetamine the week prior. Mom expressed having some mental health issues. We don't know what they were. There's no prenatal care reported, and she has 2 other children who have been adopted. She's considering putting this infant up for adoption as well. There's no concerns for the infant at birth, and there's no information on any extended family support. So that is the information that DCF received. And so that's what we make our assessment off of, is based on the information that we received. And so, Kelsey, can you go to the next slide for me? And I will add, okay, so with that information that you just heard, what are the risk factors that you heard from that situation. If you want to put them in chat, we would appreciate it. So tell us what you saw as some of those risk factors. So we got that prior meth use, no support system, or poor support, little support, drug use, mental health, methamphetamine, mental health. No perinatal care, older kids adopted. So I'm seeing a lot of little support, substance use, mental health, no perinatal care. So we've got quite a few things that we would say are risk factors as we look at that. Now, what about if we think of danger? Do we see any dangers? We think about danger for this, for the infant. So we've got concerns for lack of attachment, because it said she was talking about giving them up for adoption, the possible methamphetamine exposure, undiagnosed mental health. I think just that substance use, the concern for the impact it might have on the infant, current concerns for neglect. So I want to think about some of those, because as we think about it, we don't know if they've neglected the infant yet. We don't know if the substance use has played into it. We don't know if they have access to drugs out there. So I think if some of that is, those go back to risk almost for that infant still. We see a lot of these factors still being risk factors. We don't have anything that really is a specific danger at this point. It really is a lot of those very high risk factors that we see. How about protective factors? What kind of things do we see in here that we would say are protective factors, supports, or services? So the considering adoption. So it sounds like she's maybe talked to somebody about that. We have two parents that are together. So we have dad in the house. We don't know anything about him, but he's in the house. And and I think somebody says even she's been through the adoption process before. So it's something she has reached out to and had conversations with people about that, it sounds like. So when you hear this one, as you think about it, what are your thoughts on reporting to DCF? Is this something that you would report to DCF? So as you hear the different things that are risk factors, protective factors, and concerns for any danger, is this something you think that you would have reported to DCF? So I saw some yeses, I'm seeing some nos. I like some of the things I'm seeing in the chat. I think you guys are really thinking that through. Yeah. So I'll tell you a little bit about what this case was. And again, this is a hard one. This is one where like you've got a lot of those high risk, but we don't have a danger, but we've got some high risk, and we don't know a lot about dad. They're saying there's not that family support. And so, when we present this one, we see a pretty split room. We see a lot of people, some people really saying, you know what, I don't really have enough information. I think I would hold off on reporting, see what it looks like to work with parents. And then other people really feeling like that risk is really high. I feel like I'd want to report. And sometimes that just depends on your role. if you're working in an emergency room or the hospital, and you're only seeing the parent that one time, you're probably more likely to make that report with them leaving the hospital. And maybe if you're an in-home service provider and you've been working with them and then find all of this information out, you might hold off because you're like, well, I haven't seen some of this. I haven't heard some of this. And so I want to hold off and see what it is that I could do with the family. What supports could I provide? So again, we see a really split room on this one. And so there isn't necessarily a right or wrong answer. And I think that's what it is. I think it's about you guys really thinking through from what what is it you would do in that situation? So again, let me tell you a little bit about what it is we know about this after it was reported. So I kind of gave you the basics, and this is kind of what we found out once DCF did get involved. So again, this was called into DCF, and it was assigned for us to go out on. So what we learned was that the mom was very overwhelmed by her circumstances and was considering giving her baby up for adoption. So CPS was able to coordinate with RADAC to immediately have an assessment completed before they even left the hospital. So sometimes that can take several days, but they were able to figure out how to make it happen so that they didn't have to get on some sort of a wait list, because we wanted mom to be able to leave that hospital immediately and go where she needed to go. Mom qualified for residential treatment. CPS contacted, it looks like she went to a treatment place in Lawrence, and bed was expedited for her. Mom and baby were picked up directly from the hospital and taken to the treatment facility. So again, no waiting. We just immediately kept moving. CPS supervisor was able to provide them with a stroller, which enabled mom to be able to get to and from her classes with their baby. There was also other clothing and baby items provided for them as well. Mom successfully completed treatment and was discharged to somewhere, I can't remember what they're called. Oxford House is what this one is. I was trying not to say the exact name. And then, I haven't checked up on this one in a while because it's been a minute since we put this one in here. But as of the moment that I had added this one in here, they had hit over a year mark where they had not seen another case come in on that family. So again, I think what we're seeing is people have the ability to change. And that's what we really just like to think of is, it happened to be DCF who was able to get that RADAC assessment done, that parent into treatment, but it doesn't always have to be DCF who does that. Is there somebody else in the community that can help expedite that as well? And we saw that change really from that parent. And I think one of the things that Kelsee talks about is like that perinatal period, like while someone is pregnant and immediately after they give birth up to a certain point, she knows more than I do, is really the time that we can see change. And so if you're working with parents within that time frame, that is the time that we can see so much change happening and people really wanting to not continue on the same path that they maybe have been. So, all right, next case that we're going to talk about here is the Parker family. So this case, and again, I'm just giving you what was sent to DCF. And so these are the things we have to make decisions based off of this very small amount of information. So the meconium screen was positive for marijuana. Mom denied recent drug use. She did receive prenatal care. There was no concerns for the infant at birth, no concerns for mom's ability to parent. Mom has all the things that she needs for the baby, and she has 3 other kids that are already at home with her. So when we look at this one, what would you say are some of the risk factors for mom? So mom, there's several other kids. So sometimes that can just put higher stress on the family. So that can increase risk. Yeah. Concerns that is she being honest? So it's not necessarily a risk factor, but I think it's just that worry of the drug use. Like, was it really recent? Or meconium screens, we know that sometimes those can pull substance use from a while ago. And so maybe she really doesn't have recent drug use, and maybe it was from a while ago. Concerns for some mistrust in the healthcare system. So I'm not seeing as many things popping up for risk here. Yeah, for possible, I thought that's where you were going, was she just wasn't quite sure. Again, that fear of what's going to happen if I tell them I did, smoke marijuana a week ago. Not sure about her support system. There's no information about her support. There's no information about dad. Like, we have no idea, like, about anything with that. Yeah. So those are some things that, like, as you think about this, like, they're not necessarily risk factors. It's just they're the unknown. We don't even know what they are. And so it's hard to assess when we don't know what that support or different things might be. How about what is danger? Do we see any danger with this? So kind of going back to that drug use, and again, what is the actual impact been to that infant because of the drug use? So that would be where we're really thinking about the danger, would be really, what is it that would be happening in the next 24 hours that might make that child not be able to stay where they're at? So just the kind of concerns for the substance use, marijuana. So now, see, I see some people even bringing in there, well, we have the other kids in the house. Is that impacting them? And so again, looking at this one, a lot of what you guys are talking about in chat are still those risk factors. So a lot of things to do with that substance use. It's a risk factor, having more kids in the house. Those are all risk factors, but there's not much that really is danger in this one either. So as you think of, would you call this into DCF? Would you have made a report? Is this something that would have been reported to DCF? I'm seeing a lot of no's. And that's usually, again, the response that we get is a lot of no's. And this one was grayed out. So we did not continue to, we didn't do any further assessment on this family because there wasn't anything that was high risk factors. There was no indication of danger. There's no abuse or neglect concern that anybody had. So, but again, we see a lot of places may have policies or rules that say, any positive drug screen you report to DCF. And so again, what does that start to do for the rapport for you to work with them if there are no risk and safety things? So, all right, so let's see, next one we've got. All right, so the Morgan case study. Okay, so this one we had mom tested positive for meth and amphetamines during pregnancy and at the infant's birth. So that means, like, during prenatal appointments, she was testing positive, and at the hospital when she gave birth. We have previously provided, so she's previously been provided resources for drug and alcohol information. She had very limited prenatal care, but she did have some. She did not have any of the basic supplies for the infant, so she doesn't have a car seat, she doesn't have crib, bottles, diapers, clothes, etc. She does not have custody of 5 older children that reside with her grandmother in Texas, or they reside with their grandmother in Texas, sorry, so her mom. She has not told her parents about the pregnancy, so she's not telling the person who currently has custody of her other 5 children that she's pregnant, and she does not have a connection to any community resources. So name some of the things you see as some of the risk factors for the infant here. I see somebody just saying high risk in general. Yeah. that she doesn't have, that she's not telling her support about the pregnancy, kind of those lack of basic needs. No supplies, the positive drug test, no connections. Yeah, a lot of people are saying lots of high risk. How about danger? Is there anything that we would see in here that we would feel like we'd want to, is danger? So when we think about that infant leaving the hospital, if nothing were to change, that 0 to 10 scale, what danger do we see for that infant? Kind of that, no, there's no, where's the infant going to be sleeping? That's one that we know, unsafe sleep is a big deal. And if they don't have that, that can really place that child at pretty high risk Like, we don't know about food, we don't know about supplies. So, when thinking of this one, if I were to ask you, on a scale from 0 to 10, where 0 is that if this infant were to go home, I'm really concerned for serious harm that they might experience without further intervention. And 10 is this infant will be completely safe going home where they're at. Where would you rate this, just knowing this information on that scale from 0 to 10? 0, 1. I see. Yeah. So a lot of low numbers. I mean, and that's, when you hear this information, it's definitely one that I would say is it's very high risk, really worried about that infant safety leaving that hospital. And so I'm not even going to ask the question if you would call in a report, because I think I've already see some of I know that that's probably going to be yes. So I will just give you a little bit about what happened with this one as well after DCF got involved with it too. And let me find my notes. So this case came in and it immediately was very high risk for removal. The mom was very disengaged with her baby at first, and she'd already had all of her other children had been removed. So the kids that were with grandma, they were there because they'd been removed from this parent. Mom was very hesitant to bond with the baby. And because she was assuming that DCF was just going to take the baby. So some of her disengagement that they actually saw was almost like mom protecting herself, because she wasn't wanting to hurt herself. She didn't want to have to almost emotionally have to go through this. And so she was hesitant to bond, was very disengaged. So one of the things that DCF was able to do was use a team decision-making meeting. And so we call them TDMs. And if any of you were ever invited to a TDM, I encourage you to attend. If you hear somebody's going to be asked to go to one, ask if you can join. They're extremely important meetings. And so at this TDM, this is a space where DCF was really able to share what their concerns were to mom and give her very specific things that they would need to see from her in order to ensure the safety of her infant. They said that after that team decision-making meeting, they noticed a noticeable difference with mom, both in her willingness to actually work with DCF and then trust. And then she started even caring for her baby more. So they were able to put services into the home. And again, this is another one where over a year later, she still had custody. She did have supports through DCF and some other means throughout some of this process, but she still had custody of her baby. She was able to find a way to kind of move past some of these things that had been happening. So I think that again just goes to that resiliency that people have and that people can change. And sometimes it can take a lot. And this one, just looking at it, you really wouldn't have thought it would have turned out that way. There's so many risk factors. The thought of danger for this infant was very high. So yeah. So that is all of I think we had another one, but I think we go into if there's anything else that we need to talk about. Kelsee, I don't know, do we have anything? I've got a couple of minutes, so I can either do this last case study or questions. What do you want to do? I'll let you tell me.
I was waiting to see if anyone persuaded us one way or another in the chat. I think we have time. Let's try and get
we can do that
last
last one.
Case study in.
All right. So this last one, and again, I'm just telling you what was reported. So we've got mom is 9 weeks pregnant. So she has admitted to using fentanyl for the past year. So she's been using fentanyl for the past year. She's currently homeless, and she's discharging from the hospital into mirrors. And so, which is a drug and alcohol treatment. And so with this one, what are some of the things? So again, this is a pregnant women using substance case. So we don't have an infant that she's caring for right now. It's more about when that infant's born. And so as you read this one, is this something that, so there's not really risk or danger right now we can look at, but what are the type of things you see as protective factors that she's starting to put into place? What kind of things would you say are protective factors? Going into treatment. So we see her like already trying to get some of those services. She's admitted to that drug use, which are two huge steps that you have to admitting and then also going ahead and taking that step into treatment. So we're seeing those. Yeah. And so as you think about that possibility of, making that report to DCF, is this something that you would have made that report to DCF on? So I'm seeing several no's coming in. And I think what you guys have said above is those protective factors that she started putting in place. Well, she's admitted to treatment or admitted to using, she's going into treatment. And so she's trying to get that support. The hospital is trying to help figure out how to help get that support set up for her, so that she can give birth to a baby that's not going to be impacted or affected by those substances. So yeah, I don't know if you guys can hear these sirens behind me. So I'm going to turn my mute on. Okay, let me see. I'll pull up and see if I can find my notes on this one. We did assign for PWS, but as I look at it, I think it nowadays probably wouldn't have met our criteria because she already was seeking out those services. So again, sometimes when DCF's doing our assessment, if we already see that that parent is doing something, actively doing something, we may not also get involved. It really would be if they're not really receptive to something, they're hard to engage with. And is it something that DCF needs to be involved with to provide some more additional services? But I don't think with this one, nowadays we would have assigned that one. So thank you guys. I always love seeing the responses, and hope that's helpful to kind of walk through some of them with you.
Yeah, it looks like we have 4 minutes left, so happy to answer or attempt to answer any questions that you all have or just general reactions.
Yeah, please feel free to unmute if you have questions, or you can drop those in the chat as well.
And I'll put our contact information up here too. Eric and I are always available and willing to chat more or answer questions at any point in time. So feel free to reach out.
Kelsee and Erica, thank you so much for your session today. I'm not seeing any sessions come through in the chat, but lots of thank you. Oh, maybe there is a question that has popped up in there. Can you all see that from Brittany there?
Yeah, it said, doesn't reporting leave a paper trail for future issues that they may arise? In a way, you could say that, but at the same time, I think that, if you have a concern, you can kind of just tell us all the different things that maybe in the past it was you were concerned about. It doesn't necessarily have to be that that record should be kept at DCF. So if it's something that, maybe over a 6-month period, like you've made referrals for parents because you had concerns about something, you saw them follow through for a while, but then they didn't. So maybe you had a talk with them, and then it gets to the point 6 months later, you're like, I just really think that this isn't changing and I'm pretty worried. You can just give us kind of the history that you have done. It doesn't necessarily need to be that you're making that history with DCF as it's happening. I don't know if that makes any sense, but so yeah.
There was a second question in there, just asking, shouldn't we report to keep that record in general?
And so I think that kind of went along with the same thing, is it's just really, for you, if it's a concern that there's abuse or neglect, or there's a high risk, or there's danger that you're feeling is happening, report, and we will make that assessment decision. But if it's something that you think that, I think I can make this community referral that might just be poverty related, mental health, substance use, but I'm not really seeing this impact. There's not danger, there's not risk, there's not abuse or neglect. It's not something you necessarily have to report, just for that idea of keeping a record. Again, it can go back to, you can tell us, I made these referrals and I did these things based on some of the stuff I saw. And that helps us at least know some of that history that you might have had, but also knowing, give us the information about things that went well. What did the family do? Like after maybe something didn't work and then they changed, shifted, and for 3 months, everything was going fine. What was it they were doing during those 3 months that allowed them to be successful? So then I see, is there any way you could send the links to the resources suggested? She didn't get them all. Yeah. So Chrissy, should we just email you with, I think it was a couple of things.
Yeah, if you could email that stuff to Liz Jerome, she can get it added to the conference platform. No problem.
Okay. Yep.
All right, well, we have reached the end of our time. So thank you all so much for attending the session, and thank you, Kelsey and Erica, for presenting great content. And we look forward to learning more with the rest of the day. So thank you all so much for your time, and have a great rest of your day.
Thank you.